I first would like to thank the organizers for inviting me to give this talk. This is the outline of my presentation. There are two things I wanted to make clear from the beginning is that first, I am not going to present a comprehensive review of the literature on point-of-care testing. Rather, I'm going to focus on some of the burning issues in this area and illustrate those points with the available literature. And the second thing is that a lot of the points I'm going to make, I'm going to use examples from the area of CD4 counting because this is where we have the most experience with point-of-care testing. So I would like to start with a definition. I mean, there are many definitions and agreements and disagreements about what point-of-care testing is. The definition that I think is the one that I use most is that point-of-care testing refers to testing that is conducted very near to the patient with no requirement for lab infrastructure and that yields results in a very short time frame, allowing therefore for rapid clinical decision making. So point-of-care assays have been around for some time and I think they are here to stay. The first generation of these assays have, examples like rapid HIV assays have been around for many years. And currently, we already see a second generation of point-of-care assays that is a little bit more sophisticated in detecting things like CD4 T cells with a lot of the reading being made with instrumentation that have, for example, wireless connectivity. And probably the future is going to see yet another generation of point-of-care assays where we will be able to use other types of specimens with detection targets that are even more sophisticated and with most probably being able to do multiplexing, detecting several analytes at the same time. In the area of HIV medicine, there are many point-of-care assays that are already used. Others are in the pipeline. The previous two presentations were on HIV diagnosis in adults. We already are seeing, lots of HIV tests that can multiplex. They can detect, for example, syphilis simultaneously. We will be going to talk about CD4 T cells and viral load. There are lots of comorbidities that can be detected using point-of-care assays, things like cryptococcal antigen testing. There is point-of-care assays for toxicity, for example, measuring things like hemoglobin or liver enzymes. There are in-pipeline tests to detect resistance to ARVs and so on. So, it's not something that is so new, and there is lots of examples about point-of-care testing. So these slides, this slide and the following two are really fresh from the oven, courtesy of Laura Mazzola, who has kindly agreed to share them with us today. And these are the pipeline of point-of-care assays that is constantly updated for Unitaid. And here you can see that we already have a few point-of-care assays for CD4 counting in the market, with a few more in the pipeline. This slide used to be busier, the previous versions, but due to changes in the market and potential changes in WHO guidelines on the use of CD4, there has been many manufacturers that have decided not to develop their CD4 counting products. So this is how it looks today. The pipeline for early infant diagnosis looks like this. There is already a few instruments available that some of them under validation still that can do early infant diagnosis, with many more that you can see on the right side of the slide that are being developed many of those that are being developed are also probably going to be used for viral load testing. So this next slide is on point-of-care testing for viral load. And again, you see that there is maybe a couple that can be considered to be point-of-care testing that are already available, with smaller instruments being in pipeline, being developed. And again, many of these instruments that are being developed for viral load will most probably also have the capability of diagnosing HIV in infants. I just wanted to call your attention for the issue of point-of-care viral load. A lot of the point-of-care assays that we see are being developed for whole blood, because that makes the use of the test near to the patient easier. When developing point-of-care assays for viral load, the use of whole blood poses an issue. This slide shows some of the work that was done evaluating a prototype of a point-of-care assay for viral load. And here you can see two situations that are a complication. So the red box on the top shows the amount of overestimation that the point-of-care assay does on viral load. Because whole blood viral load is not necessarily correlated with plasma viral load, because you have a lot of virus that is associated to cells, for example, that are not detected when you do plasma viral load. The lower red box shows the specimens that were not detected by the use of point-of-care assay, because this particular point-of-care assay used 25 microliters of whole blood, and with that amount of blood, it was not possible to detect the virus in the specimen. So, I mean, these are the two, I think, big issues that developers will face when attempted to develop a point-of-care assay that works in whole blood for quantitative viral load. So regarding benefits, I'm going to illustrate some of the potential benefits that point-of-care testing has. I think the three major issues is increased access. The second issue is that we can provide better quality of care and achieve better health outcomes with point-of-care testing. And the third issue is that for many point-of-care assays, health services will become more cost efficient. And I'm going to show you examples of each one of these issues here. So first, Maureen already mentioned is that access to EID testing or to viral load in sub-Saharan Africa is a huge problem. And on the top graph, you see several countries in sub-Saharan Africa and the access that exists to EID testing. And you can see that there is a huge gap with the current format of EID testing that is based on laboratory-based instruments. And you can, on the below graph, the graph below, you can see the situation to viral load, and you can also see that there is a huge unmet need for viral load testing. So the hope is that point-of-care testing can help fill this gap in terms of access. The other issue is that with lab-based testing, a lot of the results really don't get back to the patient. And this slide shows, for example, that 55% of EID results in 4 countries are not getting to the patient. So the testing is done, but it never gets to the patient because of logistical complications of doing lab-based testing. And I mean, this has consequences in terms of loss to follow-up, morbidity, mortality, wasted resources, time that human resources spend on doing the testing, and then at the end, we don't have the benefit. So recently there has been examples of point-of-care assays that are feasible and that are accurate in hands of nurses in primary healthcare settings. And this is an example of a study that we conducted in Mozambique in primary healthcare clinics where the test was performed by nurses, and the results that we obtained were comparable to those that were obtained in the lab. And this gives us a lot of hope in terms of increasing access to EID testing. In terms of quality of care, we have here an example of how point-of-care CD4 testing can change quality of care and access to therapy. And in a study that was conducted a few years ago, it was shown that with point-of-care testing, there was significant reduction in pre-ART loss to follow-up. There was an increase in initiation of antiretroviral therapy, and there was a decrease in the time to ART initiation at primary healthcare level. So really, the use of point-of-care CD4 can impact patient-important outcomes. In terms of cost effectiveness, again, an example of the CD4 field, and some work that we have done with a group of Rochelle Walensky shows that point-of-care CD4 counting is really it can improve survival and it can be cost effective in our setting in Mozambique. This is using data from Mozambique. But the thing that is important is that the benefit of point-of-care CD4 testing was highly dependent on linkage to care. So again, the issue that was raised by the previous two speakers on linkage to care is important when we talk about point-of-care testing. Now, some challenges. The implementation of point-of-care testing has many challenges. I have listed a few here. And these challenges go from selecting the appropriate technology, deciding on where we place this technology in the health system, issues about quality management and quality control that were already raised, linkage to care, and management of expectations, because everyone expects that point-of-care testing is going to resolve all the problems that we have in the health system, and actually that's not the case. So we have to manage expectations from, at various levels: patients, health workers, politicians, policymakers, etc. So now, where do we place the instrument? This is a very nice study done in South Africa that shows a model where point-of-care testing is implemented in the context of a diagnostic network where you have labs at various levels. For example, a lab of level 1 is a very, it's a small lab in a small health facility somewhere where point-of-care testing is done, and then you have an increasing complexity of labs in the system. And so, these authors from South Africa have modeled a network, and you can see in the map there how the different colors are representing the different tiers of laboratories. And I think increasingly we realize that point-of-care testing will be in the context of a complex network of diagnostic testing. And we need to find what's the right place in the network to place point-of-care testing. Quality management and quality control, it was raised already in the first two sessions. This is going to be a new challenge as we decentralize testing to places where never before testing was conducted. And this is an example of an innovative way of doing quality control, again from the field of CD4 testing. We have in Mozambique more than 100 point-of-care CD4 instruments that are deployed throughout the country. These CD4 point-of-care instruments, they have a USB modem that can export data using the cellular phone network, and then we can collect all these in a database and conduct real-time analysis of error rates in these instruments. And this graph shows the blue bars is the number of tests that are conducted per month. And then you have the two lines, the orange line that is showing the average error rates coming down with the instruments, because we monitor, we identify sites that have errors, and then we can interact with the sites to correct problems. And the black line shows the number of sites that have errors above 10%. And you also see that it comes down because we have the possibility of monitoring it from a central location. So this kind of innovation is going to be important in deploying point-of-care assays in resource-constrained health systems. I just also wanted to show some challenges in terms of point-of-care testing that we have, for example, is examples from the field of CD4 testing, where despite having point-of-care assays in the health facility, not every patient was linked to care. And you can see, for example, that in the second red box, that the number that, despite we have point-of-care testing in a health facility, there were 21% of people that didn't have a CD4 recorded in their files, and only 55% of people got their CD4 count in one visit. So, there are challenges even with point-of-care testing at health facilities. An example from the TB field, this is data from South Africa, a paper recently published in the Lancet Global Health that shows that despite having rapid TB diagnosis, there were, in many health facilities, patient-important outcomes were not affected. So, for example, having or not rapid TB diagnosis did not change mortality risk at 6 months, or did not change the number of people that tested positive for TB, or initial loss to follow-up. So having the point-of-care assay located at a health facility is not going to resolve all the problems that we have. So we think that there are several improvements that are necessary in health systems in order to make the most of point-of-care testing, and this is the model that we have proposed in terms of improvement in several areas of the health system. So my final remarks, point-of-care testing can really increase access to health care, reduce inequities, and improve the quality and cost efficiency of medical care. Diagnostic testing will most likely continue to be performed by hybrid networks that include both lab-based and point-of-care testing. And the impact of point-of-care testing will be shaped by various factors, especially by weaknesses of the health systems. And a continuous investment and innovation in health systems will be essential to maximize the impact of technological advances. I would like to thank my colleagues at CHAI and at the Ministry of Health in Mozambique. And I just wanted to show you this last slide that, I just cannot get tired of showing this slide, but I'm sorry if you have seen it before, but this is some work that was being done in a very, very rural area of Mozambique, where these two gentlemen would either take point-of-care assays in their backpack and walk throughout villages and conduct testing, or since they are at the shore of a lake, put the point-of-care instrument in a kayak and go up the lake with the kayak and conduct testing in villages. And these villages never had any access to diagnostics before, and only things like point-of-care diagnostics can really bring diagnostics to these people. Thank you very much.